My question is, why is that mandible retruded? Why is it falling back? Why is the tongue obstructing the airway when you sleep in certain individuals but not in others? I have to be a little bit controversial but be very honest in the sense that my approach is different. It's an etiology-based approach. The tongue is supposed to rest on the palate whilst you're asleep. And classically, when you're asleep, you're breathing through your nose, the tongue is on the palate, the lips are gently in contact, and the teeth are slightly apart the freeway space. If you have a patient with a class 3 malocclusion and they also have a diagnosis of obstructive sleep apnea, where are you going to put the mandible? It's already protruded. We start with the cranial base. I have a kind of little phrase that helps people just remember this. The cranial base sets the pace for the rest of the face. And all of that rhymes. A malocclusion is a solution for a complex adaptive system. That is a malocclusion in my understanding.
Welcome to the controversial world of airway and orthodontics. We are joined today by Dr. Dave Singh. He's someone who's literally just finishing his tenure at Stanford University. He initially qualified in the UK and then moved to the States and worked with some of the biggest names in orthodontics. The title today is Craniofacial Sleep Medicine. This episode's similar to themes discussed with that episode with Dr. Liz and Dr. Megan, but it's not so much about, the sleep studies like we've discussed before or mandibular advancement devices, because the craniofacial sleep medicine element looks at anatomy. So whilst in the dental sleep medicine world, we may help someone's sleep apnea with either a CPAP machine or a mandibular advancement device to stop their jaw from falling back, allowing the patient to breathe better in their sleep. In this context, that could be regarded as putting a plaster. It's treating the symptom, not the root cause, because the root cause could be anatomical. It could be a narrow maxilla, a high arched palate, a scalloped tongue that just does not have enough room. And so this episode really does take an anatomical and epigenetic approach. After we recorded, I was reading more about the orthodontic societies and what they believe. And actually there's a lot of friction or controversy about the kind of stuff that Dr. Dave Singh discusses with us today. There is data and evidence for it, but one of the appliances that Dr. Dave Singh invented expands the maxilla on adults. And what I was taught when I was doing my diploma is that actually you can't do that. After a certain age, you can't expand the maxilla anymore. But Dr. Dave Singh says you can. Even in adults, you can have significant structural change, enough to improve their breathing. Isn't that fascinating? Hello, Protrusive, I'm Jazz Galati, and welcome back to your favorite dental podcast. I really want to dive into this hot topic, so I will just leave you with your Protrusive Dental Pearl. Every PDP episode, I give you a pearl. The pearl is very simple and related to the topic in hand, and that is to get rid of this myth that obstructive sleep apnea is a fat old man disease. We used to think this, but it's not the case. A lot of the GPs I deal with still think this, but it's not the case. We need to be screening everyone for airway issues. We need to be asking about their breathing. We need to be asking about every patient's sleep. I've been sleep testing my patients for the last couple of years. It's been really fascinating. The conversations you learn about their sleep, and then you look at their anatomy and their sleepiness scale, or the impact that just even simple snoring, simple snoring could be having on their partner. And of course, many theories between obstructive sleep apnea and Bruxism, and actually Dr. Dave Singh touches on that today. So once again, it's not a fat old man disease. Let's be vigilant, and to build on that narrative will be this entire episode, which will give you so much more insight. So I'll catch you in the outro. Professor Dave Singh, welcome to the Protrusive Dental Podcast. It's an absolute honor to host you. I've heard so many great things about you, and the topic we have is absolutely amazing because it's such a topic that confuses a lot of people, and you're very fascinating to me. You qualified in the UK, and you were essentially, like from our pre-chat, you were headhunted by the US, and then you were started off as an associate professor. Now you're a professor in the US. So please, for our listeners, can you introduce yourself and give us a taste of your journey? And especially, I want you to end with how you niched into sleep medicine before we then talk about craniofacial sleep medicine.
Well, Jess, thank you for inviting me. It's great for me to be here and address a UK audience. Yeah, so it's a very long and interesting journey, and this was never planned. It just worked out that way. So yes, originally born in England, went to the US for a sabbatical, actually to Canada, and the Canadians sent me down to Michigan. And the long story short is that I visited the US as a visiting professor for about 3 years, and eventually they sent me an invitation to relocate to the US as an associate professor. And the reason why I took that opportunity is because it was a center for craniofacial disorders. It was a multidisciplinary team with the plastic surgeons, the orthodontists, speech pathologists, all working together. And so it was unique in those days to have a craniofacial center. And it was a lot of fun. We were very successful there. And part of my findings during that time led me onto a side track into sleep apnea. And that's a long story in itself, but imagine the children with craniofacial anomalies, such as APA syndrome, Crouzon syndrome, so on and so forth. In those days, we were doing a new technique called distraction osteogenesis, which is well known now. And what we were doing with these children is actually doing either midfacial distraction osteogenesis or mandibular distraction osteogenesis. And part of my findings was that when you did this procedure, the airway behind the jaws increased in size phenomenally. And I thought that would be a great kind of approach to take for sleep apnea if I could reproduce that non-surgically. And that's where my journey really started.
It was at a time where, I mean, now we're learning more and more about this. It's practiced more and more in general practice. I myself am carrying out home sleep tests for my patients, reported by a sleep clinician. Even now, it's not even mainstream, especially not in the UK. I feel as though our colleagues in the US and Australia, from a UK perspective, I know you mentioned the UK, but we are a worldwide podcast. So a lot of countries, they're a little bit behind when it comes to airway and generally sleep medicine. So there's a lot to unpack, and I really want to give everyone a flavor. But your background is like academic or wet finger dentistry, and then you kind of fell into this niche of sleep medicine.
Yeah, so my, first of all, all my kind of qualifications were validated in the US. First of all, as a doctor of dental medicine. Second, I have a PhD in craniofacial cleft lip and palate, and that was done at Bristol, and part of that was Frenchay Hospital, Bristol. And then I did a third doctorate in orthodontics, a Doctor of Science in orthodontics. So that's my basic training there. I did start on the FDS pathway as well, but I got sidelined by my PhD, and that kind of just took off, and I was really enjoying what I'm doing, so I stayed with the game. And that's what eventually brought me into, the area of sleep medicine. Because at that time, people were talking about snoring and using a device to reposition the mandible. I'd done a lot of research on twin blocks and other devices as well, so I knew in a fair amount of detail how the twin block device works. And so I thought to myself, and I also knew the downside of those techniques as well. And so I thought there has to be a slightly better solution. And that's what got me going in terms of, developing these new ideas and approaches.
And so this leads nicely onto, there's a whole umbrella of sleep medicine, but then now it's like dental sleep medicine. We're putting the word dental in front of it, so to make it more applicable to us. So Professor Singh, what do teeth and sleep have in common? Like, tell us about the links and why those dentists who perhaps are not doing screening, are not discussing sleep. What do you think should be our role in general dental care?
So I'm a former professor in sleep medicine at Stanford. I actually finished there September of this year to focus on my new company, which is called Rima Sleep. So my disclosures are that I'm a founder of Rima Sleep and also the founder of Vivos. And Vivos was my company because I was the inventor of the DNA appliance, which was the first powerful expander to be FDA cleared for sleep apnea in both children and adults. And so when you think about craniofacial sleep medicine, we first of all think about the specialty of sleep medicine itself. And there are about 65 known sleep disorders and a few variants as well. And the one that the dental profession tend to focus on is sleep disordered breathing, and that kind of branches off into what you might call dental sleep medicine. In my experience, dental sleep medicine is mostly surrounded by, mandibular advancement therapy, it's mandibular manipulation, and that's a good tie-in with most general dentists, especially those that have a background in TMJ, TMD therapy. But of course, these mandibular devices are being used to treat both mild, moderate, and even severe sleep apnea medicine. So the dental sleep medicine, is predominantly based on mandibular advancement devices. And that's kind of interesting because when you think about the emergency situation where a patient collapses or someone collapses, the idea is to open the airway by pulling the mandible forwards. That's where the idea actually came from. But I'm not so sure if that's a long-term solution for people who have a diagnosis of sleep apnea. And it's interesting that dentists
And
have
so I guess one doubt I've had, Prof, is when I have someone and we do a sleep test and they come back as mild to moderate, then it's a bit of a grey area because our guidelines suggest that perhaps this patient doesn't need a CPAP and they benefit from a mandibular advancement. So for one of our students, listeners, or new colleagues, a appliance that brings the jaw forward, or a better way that it was explained to me is stops the mandible from dropping back, thus keeping the airway patent, giving the tongue more space. And please do correct me if I'm saying anything that is not the best way to say it. But these appliances is something that we as dentists can help our patients with. But the problem is a lot of dentists, myself including, like we are like, okay, well, if it's not CPAP, it's a mandibular advancement. We don't know what other options there are out there to help our patients. And I'd love for you to sort of break down what other ways we can help our patients. I don't know if that's part of the remit today.
Oh, absolutely. I mean, it's a wonderful question. It's a very big question. So let's look at this from, a kind of empirical point of view. So bring the mandible forwards. The idea is that you will bring the tongue forwards and open up the airway. That's a generic idea. And if you look at patient profiles using endoscopy, such as DICE, which is drug-induced sleep endoscopy, and then look at the behavior of the airway when you manipulate the mandible, you can see whether it has an effect or not. So this goes all the way back to my initial training on the cleft lip and palate children. We put an endoscope down their nose, and we were looking to see how well they were able to seal the oropharynx, after surgery. So that's where I decided to kind of be able to assess airway behavior. Now, again, generally speaking, about 1/3 or about half the patients, if you bring the mandible forwards, the airway will open. And so you will get an immediate effect in about half, maybe 1/3 of patients. But in the other half, or the 2/3 sometimes, you will not get that effect. So generically, yes, it's a good idea. It may or may not be the most appropriate protocol for that individual patient. Number two is the idea.
Prof, correct me if I'm wrong. When we give this mandibular advancement, we say go home, try it out. We are relying on subjective measures, which will give us, oh, my snoring's improved, or I feel better. Where that's like subjective feedback from patients. But what you mentioned about the drug-induced, is it endoscopy? Is that I've got that right?
Yes. Yes.
So there's a colleague I saw, Dr. Lukasz Lashman in Poland. He posted wonderful. He's a dentist. He posted a wonderful Instagram video of having someone there doing that, and then he was giving, I think it was like a tap appliance or something. He was titrating it, he was twisting it to advance the mandible forward to now meet objective aims of it. He was actually visualizing the airway opening, but we don't always in primary care we don't have access to that. I mean, if we took time and money out of the equation, would that be the gold standard way of delivering a mandibular advancement device?
It would not be. And so I have to be a little bit controversial, but be very honest in the sense that my approach is different. It's an etiology-based approach. So my question is, having gone through various kind of, experiences, my question is, why is that mandible retruded? Why is it falling back? Why is the tongue obstructing the airway when you sleep in certain individuals, but not in others? And so when you think about why is that mandible retruded, the short answer is developmental compensation. So when the body is developing, it essentially follows a craniocaudal gradient from the top down. So what happens is the cranial base gets there first, undergoes maturation first. The midface, including the nasal complex and the midface, follows suit, is second, and any space that's left is then going to be occupied by the mandible. It's craniocaudal, and eventually you'll get some kind of signs also on the hyoid bone as well. So when I see a patient with a retruded mandible, the first question I ask is, why is that mandible retruded? Number two is saying a therapeutic approach. Well, I'll just bring the mandible forwards. So what you had is developmental compensation, the mandible's back, and then what you do is non-surgical decompensation. You just push the mandible forwards. And again, empirically, that's a fine, nice principle to follow, but it hasn't addressed the underlying cause to say, why was that mandible retruded in the first place? Add on to that, why is the tongue falling back whilst I sleep? Now, long story real short, when I woke up this morning, two things happened. First thing, I want to know where is my tongue in space, and my tongue is sitting on my palate. And number two is, did I remember my last dream? And the answer is yes, and it was weird. So the point here is that, the tongue is supposed to rest on the palate whilst you're asleep. And classically, when you're asleep, you're breathing through your nose, the tongue is on the palate, the lips are gently in contact, and the teeth are slightly apart the freeway space. So that is the homeostasis. That's craniofacial homeostasis. That's upper airway homeostasis. That is our gold standard. And now the question is, why is that mandible retruded? Is there something upstream, the midface or the cranial base or something else, which is producing that clinical signs and those symptoms? And we can do a, symptom-based management, or we can say, let's have an integrative endotype-based approach to say, here's the underlying condition. Let's see if I can actually correct that.
Okay, so are we alluding to the mandible is restricted or underdeveloped because the maxilla was restricted or underdeveloped, and it follows suit?
That's yes, and we go even further up. So I always start with the cranial base. And I have a kind of little phrase that helps people just remember this. The cranial base sets the pace for the rest of the face. And all of that rhymes. So if you look at the cranial base, in modern humans, Homo sapiens, the human genome has been sequenced. But for modern humans, generally speaking, there are two cranial base phenotypes. You've got the short cranial base phenotype and the long cranial base phenotype. So for the long cranial base, generally it's Caucasian people, Middle Eastern people, people from South Asia. They tend to have a long cranial base phenotype. On the other hand, people from North Asia...
Is that the good one or the bad one?
Say again?
Is that the good one or the bad one?
Oh, they're both the same. They're both the same.
Okay.
It's just a morphological, it's just kind of, a classification based on cranial base morphology. So they're both good. They both work. So the short cranial base is North Asia, East Asia, and Africa. So now when you think about cranial base morphology, the people with a short cranial base have a tendency to have a class 3 malocclusion, a prognathic mandible. And the people with a long cranial base have a tendency more towards a class 2 kind of facial profile where the mandible appears to be retruded. So now here's my question. If you have a patient with a class 3 malocclusion and they also have a diagnosis of obstructive sleep apnea, where are you going to put the mandible? It's already protruded.
Yeah. Absolutely. But just so we can go back to basics, when we say the cranial base, what bones does that consist of? Is it like sphenoid, and like are we looking at the maxilla? Like what bones are consisting of that?
So cranial base at the front, you've got the ethmoid bone, and that's going to form, the very top part of the nasal cavity, and then behind that you've got the sphenoid bone. And behind that, you've got the occipital bone. So in a sagittal view, that would be the three bones lying, in the cranial base. Now, the interesting thing is between the sphenoid and the ethmoid, you have a synchondrosis, the sphenoethmoidal synchondrosis. And that is a cartilaginous site of bone formation, which elongates the cranial base. And so as the cranial base elongates, the midface, which is attached to the anterior part of the cranial base, can translate forwards in space. Now, the human face doesn't grow forwards very well, but it does grow forwards. And as it does so, the maxilla is translated forwards anterior in space. Now, the maxilla itself grows backwards. So what happens is it's moving forward, but it's growing backwards. The first molar, the second molar, and then the third molar are all going to erupt into the space vacated by the anterior translation. And if that's deficient, you'll end up with, third molar impaction, for example. Also, if the maxilla doesn't develop very well, you end up with a more severe class 3 type of facial profile.
And so what's the number one etiology of that not developing, the midface and the maxilla not developing? To his true
That's a great question.
Potential.
So why wouldn't the midface develop as well as you would like? And my kind of approach to that is epigenetic, because the human genome hasn't changed for 30,000, 40,000 years, in terms of, the Homo sapiens. And if you go back historically, the third molars usually were fully erupted and in occlusion. And so what happened? Did the teeth get, what happened to the teeth during that time? What happened to the bone during that time? So one of the things that, early on people used to talk about was the idea that, well, the bones are getting smaller. That doesn't make sense because if you look at the historical or the evolutionary record, for mammals, specifically humans, the teeth have been getting bigger as evolution progressed. So you have the trigone, which is a 3-cusp tooth. You have the talon, which is a 4-cusp tooth. You've got the Dryopithecus pattern, which is a 5-cusp tooth, which we are familiar with. And now we even have things like the Carabellis tubercle, which means that modern teeth are huge. They have these 6 cusps, potentially at least 5 and maybe 6. Not only that, the enamel in modern humans is the thickest enamel that we have had in terms of evolutionary history. So our teeth have been getting bigger over a period of time, and it makes no sense for the bone to get smaller. So the reason why the maxilla is underdeveloped, there may be some epigenetic influences. And the biggest one you can think of is there's been a sharp shift away from breastfeeding, away from suckling, away from nursing at birth. So remember, humans are mammals, and the young are going to suckle at birth. And if these babies or children did not suckle or breastfeed, 10,000 years ago, that baby would not have survived because there was no formula, there was no bottle feeding available at that time. So one of the biggest shifts we've done is the child rearing practices, and that happens very early on in modern societies.
And do you think the orthodontic societies also, do they like argue about this? Because I feel as though there is some argument that they say that actually is mostly genetic, and that perhaps the epi part of it is not as well respected. And do you think that whole thing about our diets are becoming softer and therefore we're not developing to our full extent is because of that change in diet over the years and have become more industrial and farming? Is that also a factor to play?
Absolutely. Is it controversial? Yes. The reason for that is it just takes time for the evidence to emerge. And if people are not researching these areas sufficiently, then the momentum is lost and it's kind of, people just kind of ignore it, if you will. But the epigenetic factors are strong. We have done studies where we compared babies and children who were breastfed versus those who were bottle fed, for example. And in this study that we published, there was about, I'm just guessing now, I forgot the exact numbers, but about 50% of the kids who had deficient breastfeeding had increased likelihood of having a malocclusion, crowding, and that kind of stuff. Now, does diet play a role? Absolutely. Because you go back 30,000 years, we had a non-refined hard diet. And this brings us back to big teeth.
Usually I've heard about our jawbones getting smaller, not so much about teeth getting bigger.
Yes. So this is the idea is that in terms of why would you have bigger teeth in terms of evolution. So during the time when the evolution was happening, humans, Homo sapiens, also had another revolution. It's called the Big Bang Theory. The Big Bang Theory, there's one that refers to the creation of the universe. That's a separate one. But the Big Bang Theory in terms of human evolution is that we developed these massive brains very quickly over a short period of time. And so this is why we have these large and fragile brains. And the genes associated with that are the HAR region. That's a human accelerated region. There are about at least 6 genes that produce specific proteins to enhance brain development in humans. So now you think about this very large and fragile brain, and you have a very hard, non-refined diet. So these big teeth, these big molar teeth, are going to dissipate forces away from the brain. They're going to use the architecture, the craniofacial architecture, to absorb those forces and prevent microtrauma to the brain. And we know that trauma to the brain is not a good thing. It might be something like concussion. It could be an athlete. It could be in a military situation where you have a force that impacts the brain and suddenly, you're knocked out. And then you have the post-traumatic stress disorder and all those other things that can follow from a severe concussion. So the idea to have large teeth and large jaws is to actually protect this very large brain of ours, which also needs a large blood supply, so it's very well oxygenated. And so when you think about teeth and sleep, what do they have in common? It's really about the lifespan. They are predictors of lifespan. They are predictors of longevity.
Fascinating. So there we are. It's protect our brain. Goes back to the origins and evolution.
Absolutely. And again, the studies coming out from there are far and few between. But the studies that we have done, we were able to reduce the risk of concussion in high school footballers by having a mouth guard. So the mouth guard is to prevent, dental trauma. We understand that, but in addition, it actually protects the brain. And so when you think about, boxers who wear a mouth guard, it's essentially to prevent the concussion, because if you take a blow to the chin, kind of classify them into a small blow on the chin, which can be absorbed by the bone and doesn't produce a concussion. Number two is the other extreme, where the blow to the chin is so large that you get a fracture of the mandible, typically a condylar fracture. And by fracturing, the brain itself has been protected and the bone has been sacrificed. But the one that's in between, the intermediate force that is applied to the mandible, the condyles are rammed up into the temporal fossa, and you get atypical temporal lobe activation, and that is what causes the concussion. And that's a long story real short. And that's the one that we are trying to protect in athletes specifically.
Okay, wow, I didn't know that, and it just gives another reason to help protect our athletes in primary care to make sure that they are reduced risk of concussion. I think the way you described it makes absolute sense. Now, when it comes to, again, the whole topic of dental sleep medicine, but we're talking about craniofacial sleep medicine, what would you pose as the key difference there? So tell us more about this difference from dental sleep medicine as we know it, as we've discussed, and as the sort of little boom in dentistry of discussing these topics, whereas craniofacial sleep medicine, like you said, is etiology based. You said, well, we're looking at the root cause. Tell us more about that.
Yes. So if you think about, the diagnosis is obstructive sleep apnea. But behind that, there's at least 4 different endotypes. And so classical one is the craniofacial one. For example, you said that the mandible is retruded. There's an obvious anatomical variation there. So number 1 is, a craniofacial type. Number 2 is it may be neurologic. So the reason why this person has sleep apnea is because there's some kind of issue with the neurology. And we can think about, different examples of that, such as arousal threshold. And so this patient or this individual, when they're asleep, they have a low arousal threshold and they are woken during sleep. And so there's a neurological component. There's another group of individuals who have high loop gain, and high loop gain, again, is really the control of ventilation, the control of breathing. And if they are hypersensitive, they have high loop gain, they tend to overcompensate, and they can end up with producing a worse situation and actually depressing breathing. So there are some neurological kind of endotypes of sleep apnea. And then number 3rd one would be the kind of hormonal or metabolic one, which is really obesity. So these are people who have a high BMI, they're overweight. And so what happens when they lie down is they increase the work of breathing. There's an increase in ventilatory load because you've reduced the lung volume. It's physically harder to breathe. And so there are different endotypes of sleep apnea. It could be metabolic, it could be neurologic, it could be craniofacial. And then the 4th group is myopathic, because once you get past the oropharynx, now you're into the pharyngeal region, that airway is predominantly muscular. And if there is a lack of muscle tone, there's an increased risk of upper airway collapse. It will reach the critical collapsing pressure. Once it gets there, it will collapse. So that's an idea to say, well, why is that muscle tone so deficient? And so that's another example of saying, hey, I need to address the muscle tone in this case, as opposed to, for example, a craniofacial condition in a different case, or there may be an overlap.
Would you say that in the current state of affairs around the world, because you're in the best position to answer this, but do you think that the current state is they may or may not have a sleep test, and that may give them an AHI that may suggest that, okay, they will benefit from a mandibular advancement device, but it's just given without thought to, is there, like you said, the myotonic, is it hormonal, is it this? It's just a one-size-fits-all to try and see if this suffices the patient's needs. Do you think this is where we're currently at?
I think you summarized it pretty well, Jazz. It's almost like a trial and error, but this is part of it is because it's license-based. If you have a dental license, you practice in a certain way. If you've got a medical license, you practice in a certain way. And my idea is just saying we have to look at the condition overall and what is the most appropriate treatment for that individual. And the way that these people turn up for treatment can be either direct or indirect. They may have a diagnosis of diabetes, they may have hypertension or other cardiovascular diseases, they may have dementia, they may have obesity, so on and so forth. And underlying these conditions, there may be an undiagnosed, diagnosis of sleep apnea. And so when your patient comes to the dental office and you're going to do maybe a surgical procedure, you can take a blood pressure measurement, or you can ask the patient, are you taking meds for hypertension, so on and so forth. So if there is a history of hypertension, then there's a chance that this patient may actually have undiagnosed sleep apnea in addition to that. And so what we're going to do is maybe do a pre-screening. In other words, we're going to look at this patient's craniofacial features and saying, is there any features here that make me suspect that you may have undiagnosed sleep apnea? For example, the mandible is retruded. And then number two, you can go on to screening, which is a questionnaire to say, answer these questions. For example, the Epworth Sleepiness Scale. There are other scales as well. And then if the questionnaire comes out with an increased risk of sleep apnea, then you may go to either a home sleep test or a PSG. And it is becoming easier to do these tests. You can get now a home PSG or a home sleep apnea test. And based on the outcome of that test, which will be read and interpreted by a physician, the physician will say, hey, this patient has, mild sleep apnea based on the apnea-hypopnea index, the AHI, and therefore we can look at different forms of treatment options.
I'm just going to clarify that. So if the diagnosis comes back as mild, I just feel that the current default is, okay, they're mild, therefore mandibular advancement. How can we equip dentists in having the right knowledge and referral, or do you think that this is something that dentists can manage, just knowing when to use the mandibular advancement device and when to refer to for something else, or when to carry out something else? How can we unbox this for dentists to make it tangible? Because right now, many dentists are just used to, okay, the patient's snoring, they have an AHI of 10, they're a little bit overweight, or they have a retrusive mandible, the partner complains of snoring, therefore mandibular advancement device, but rather, what's the root cause, and let me find a purpose-built therapy for this cause.
Sure. And remember, this is really referred to as oral appliance therapy as far as the dentist and orthodontists are concerned. And so now we say, okay, beyond mandibular advancement devices, are there any other devices out there that would be placed intraoral and have a beneficial effect? And the answer is yes. And this is where education, information, and training comes in. And the whole purpose of holding these types of teaching events and seminars and so forth is to be able to share a broader base of knowledge. And so the more information you have, the better decision you can make based on the information.
It's all about diagnosis, isn't it, Prof? Because diagnosis is not just OSA. It should be OSA due to this factor or that factor or that factor. It's a bit like when we diagnose periodontal disease. It's periodontal disease due to smoking, or due to poor hygiene, or due to having a aggressive form that's genetically linked, and then treating that accordingly. Am I talking sense here?
Absolutely. That makes complete sense. And again, thinking about the diagnosis of mild sleep apnea, for example, let's go a little bit upstream and make it even less severe. Now we're talking upper airway resistance syndrome. In other words, this patient had a sleep study and the apnea-hypopnea index was less than 5. Okay, they did not have sleep apnea. However, they report sleepiness, maybe they have fatigue, maybe they have chronic pain, maybe they have headaches, and generally not speaking very well. So I actually met, I was at the conference last weekend, the American Academy of Sleep Medicine. I was presenting some findings there, and I just happened to meet someone, at the conference. And when I shook her hand, her fingertips were really cold. And she said to me, oh, I have sleep apnea. And my kind of idea was, it was just a discussion just based on this. And I said, you probably most likely have upper airway resistance syndrome. And she said, what is that? I said, well, one of the reasons why we sleep is actually to conserve energy. And by doing that, we actually elongate the lifespan. So we spend about a third of our lifetime sleeping. And sleep is a microform of hibernation. So when you think about hibernation, what happens is that you're in a cozy den, it's dark, it's cold outside. You get peripheral vasodilation. your breathing slows, your heartbeat slows, your blood pressure comes down, and you conserve energy. And the bears and other mammals that hibernate do that for about 2 or 3 months a year, and it elongates their lifespan. Humans do something similar every night. And so now when you're conserving this energy, your core body temperature goes down.
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
Now, let's say this individual with upper airway resistance syndrome, they are about to have an episode of apnea, but they wake up momentarily and they fall back to sleep again. And so what happens is they have sleep fragmentation throughout the night. In other words, when they wake up in the morning, they're not fully rested. They're not kind of, in a severe condition, but they're not optimal. And one of the ways the body's going to conserve energy during the day is peripheral vasoconstriction. And so when you when talk to some of these people, they have cold fingers and cold toes, and they may have a history of TMJ problems, chronic pain. And typically, if you said to me, pick out an individual like that, it'll be a non-obese younger female. That would be a classic way of saying you may have upper airway resistance syndrome as opposed to frank sleep apnea.
And now that must be very difficult for us to diagnose as dentists. So for example, I'm so happy you're talking about this, because I literally have a patient I'm seeing right now who, and tell me again, because I'm learning from you here, the validity of my thought process. His history was that when he had the Aura ring where he's measuring his sleep, every night, there was not a single night where his his sleep metric came back as restful. His sleep was always restless, and he had all the other signs of just feeling tired, and he looked just generally like a bit pale and tired. And I worried for him, and I'm gonna be doing some major restorative work because he's got some major wear. And before I do this, okay, I need you. I'm a little bit concerned. I think you may have some sort of sleep disordered breathing. So I've got his results back. I'm gonna get reported now, but AHI of 1.
Right.
And so how do I, I'm convinced he has, and he's got very small maxilla, small mid face. And one of the reasons why I think he's got wear is because his mandible is outgrowing his maxilla, is what I'm seeing. And so how can I help to confirm this diagnosis of upper airway resistance syndrome, if I'm right, if you think I'm barking up the correct tree here, and also what are the treatment modalities available once we get that diagnosis to dentists, or is this out of the dentist's hand then?
Well, because sleep disorders are a medical condition, they have to be diagnosed by a medical physician. It could be a sleep specialist, an ENT, a general practitioner, whoever. But the actual sleep study the diagnosis has to be made by a physician. Once you have the diagnosis, you can then say this patient would be a great candidate for fill in the blank, some kind of oral appliance. Now, you mentioned tooth wear. Remember, I mentioned that humans have the thickest enamel, modern humans have the thickest enamel that we've had historically. So if that enamel is worn away, the question is why? And again, you've talked about restorative, and we have done some of these cases. We actually published to say, even though the patient walked in with severe wear, that was not our primary concern. Our primary concern was to ensure that the patient has a healthy, profile systemically, and then we go on to the restorative after that. So let's think about sleep bruxism for a second, since that shows tooth wear. And the idea was to say that people who have some kind of issue when they're sleeping, they're going to brux and grind during sleep. And the idea was some kind of protective reflex to open the airway and keep them, oxygenated whilst they're asleep. That hypothesis has not been borne out. Now, does bruxism occur? Yes. Do you get flattening or wear of the teeth? Yes. But what's the underlying, reason? Why would you brux to try to open the airway? And so, long story real short, this goes back to the trigeminal cardiac reflex. And again, I'm showing you these scenarios for us to get an idea in terms of how we'd explain that. And we'll talk about the restorative stuff in a second. But let's just go way back in history and say, here's a young child, the daughter of a caveman. And she's walking, and suddenly she slips and falls into this icy lake. And she's going to, drown. Well, what's the body's reflex? That very cold shock, especially to the face and the trigeminal area. What it does, essentially, it slows down the heartbeat, and you get dilation of the blood supply to the brain. So basically what you did is said, okay, if there's one organ I have to protect to stay alive, it's going to be my brain. And what we find is when you grind and clench, you actually increase the blood supply to the brain. So possibly that's the reason why you brux. It's a primitive reflex that is kind of playing out inappropriately in modern humans. And again, that's the hypothesis. Now we say, okay, well, we've got these.
What would trigger it in the sleep though? So I understand that when there's a traumatic event like falling in that cold lake, that's in the trigger. So why is it that some people are bruxing in that manner that you described? What's the trigger? Is it the fact that they're not able to breathe?
Yes. So if you fall into the lake, obviously you hold your breath and you become hypoxic. And when you have OSA, when you have apnea, you have hypoxia. Okay, you have oxygen desaturation of the blood. And that's a signal to say, I need to survive, I need to do something. And one of the primitive reflexes may be to say, okay, I need my brain to be healthy and divert the blood supply to the brain. It's a bit like the flight or flight reaction where you just redistribute, vasodilation to the muscles and so forth in that kind of situation. So again, it's a hypothesis. But the point here is that...
Can I just clarify that what you're saying is, and there's a little nuance here, and I'd love for you to just confirm this, is where, and I'm just summarizing what I think you believe, and I'd love to share this with our audience to highlight this, is where we think that the reason we brux could be to open the airway. So some people have said protective function or parafunction or the bruxing is a protective behavior to open the airway, perhaps. What you're suggesting is actually the bruxism is to divert the blood to the brain in response to the hypoxia. Have I got that right?
So my original hypothesis, it was actually a little note in the British Dental Journal 2007 called the spatial matrix hypothesis. Since that time, it's been, improved. But the idea is that bruxism clenching does not actually open the airway. That was the idea. So some of the early studies by people like Simmons and other people, they said that when you are in a state of bruxism, what happens is that when you clench, you start getting increased masseteric activity. The masseters are going to clench. And they said that when the masseter clenches, it protrudes the mandible and opens the airway. That was their idea. Of course, that doesn't happen because the masseter is a jaw elevator. It does not protrude the mandible.
It would be the lateral you want to go, which is what the bruxism, the left and right synchronous grinding happens.
Correct. So I think bruxism, or, rhythmic mastery muscle activity, is some kind of primitive reflex which does not open the airway per se. Now, again, when we think about airway behavior, this is what we're coming to now. So, for example, when you expire, the upper airway starts to get smaller. And if it reaches a critical collapsing pressure, it will collapse in on itself. And we want to prevent that from happening. And so what happens in the CPAP people, so CPAP is continuous positive airway pressure. It's the treatment of choice for physicians throughout the world. Now, it's a good option, but in my opinion, not the best option. Does it work? Yes, it does. Should you use it? Absolutely. But again, did you address the underlying etiology to say, why is that airway collapsing during sleep? And so what the CPAP does, as you probably know, is you wear a little mask over your nose and mouth maybe, and it's blowing air into your airway to make sure it doesn't collapse, just like blowing up a balloon, give an analogy like that. And then the idea is to say, okay, now I have to kind of exhale and keep repeating that. Some people don't like that because it's overriding their own breathing physiology. The machine is breathing for you. And to make a bad situation a little bit worse, most of these people with sleep apnea have healthy lungs. They do not need ventilatory support per se, unlike people with COPD, for example, chronic obstructive pulmonary disease, or interstitial lung disease, for example. Those kind of people do need ventilation. However, most people with sleep apnea probably don't need ventilation per se. I'm not saying you shouldn't use a CPAP. I'm just looking at the underlying idea behind it. So now we have a variant of CPAP coming out, and instead of having continuous pressure, it actually provides intermittent pressure. In other words, the air being blown down your airway is only applied when you exhale. So when you exhale, the airway starts to get smaller, and that is the point at which it may collapse, increased risk of collapse during exhalation. That's the lowest pressure. And so at that point, they apply the pressure, the air pressure from the intermittent PAP, and that prevents, the sleep apnea. Again, they haven't really looked at why the airway is collapsing, but it just shows you that we need to understand upper airway behavior a little bit more before we decide which is the most optimal therapy in a particular case.
Then going back to my patient and with the potential upper airway resistance syndrome, because obviously he's going to get reported by the sleep clinician, and is the upper airway resistance syndrome something that's managed with CPAP, or what are the ways that we can, obviously the sleep physician will confirm the diagnosis, but what's the culture, what's the trend like in diagnosing this? Because the symptoms and signs and everything's pointing, and also the sleep metrics that he shared with me, everything is pointing to having I'm convinced there's definitely a sleep issue.
Right.
And the wear and everything's pointing towards it, but his AHI is not matching up. Therefore, it points us towards this upper airway resistance syndrome. But are sleep physicians happy to make such a diagnosis? Do they use a different screening or different test for this?
There's not a different screening. There's not a different test. But again, it's about patient management. What are you going to do? So let's take a large population that has an increased risk of upper airway resistance syndrome, and those are called children. So kids tend to have, if they're going to have, some kind of airway issue, it's probably going to start as UARS. It might present as both frank, mild, moderate, even severe sleep apnea. And so now we just look at these children to say, where is the resistance coming from? Classically, you open the mouth, you look down the throat and look at the size of the tonsils. If it's not in the tonsils, then you can look at the nose to see, do they have allergies, nasal obstruction? And the same rules apply for adults as well. So we're going to find out where is the resistance coming from. And classically, it's craniofacial in the nose. And now what we know is the floor of the nose is the roof of the mouth, also known as the palate. And so, especially in children, but actually also in adults, you can do palatal expansion in these cases. Now, palatal expansion, in my opinion, is a historical misnomer because the orthodontists were a great group of the profession, looked at the palatal width and tried to expand it, widely, kind of medial laterally. But the palate itself and the maxilla, it's a three-dimensional object. And so you have to really say, I need to maximize or optimize that structure, its morphology in 3D and not simply make it broader. And so when you talk about the 3D aspect, and when you think about children, even adults, who have upper airway resistance syndrome, one of the things you might be looking for is, do they have a high arched, narrow palate? So the idea is not just to widen the palate, but I want to flatten the palate. And when you flatten the palate, you actually increase the nasal volume, you decrease the nasal resistance, you increase nasal airflow. And in fact, some studies coming out showing that dentists can do that using various different types of devices and approaches.
So I was always taught that in children, yes, you can expand certain ages, rapid maxillary expansion, but in adults, it's mini screw assisted expansion, MARPI. Are there, because if you try and expand like using clear aligners or fixed appliances, that's not true expansion. You're tipping the molars. So in some of the previous episodes, we talked about MARPI. Is that what you're suggesting, or is there something else that we're missing?
Well, again, this comes back to my disclosure. I'm the inventor of the DNA appliance, which became the first palatal expander to be FDA cleared for treatment of mild, moderate, severe sleep apnea in adults and in children. And so as my research, what it kind of showed is, what is, going on with palatal expansion? Why is it that we have to, quote, split the suture? Now, when you split the suture, it's really a bone fracture. And so we didn't understand historically the structure or behavior of the craniofacial sutures, which includes things like the mid-palatal suture. So if you look at how these sutures behave, like any other system of the body, they are subject to sutural homeostasis. They have to be in a state of balance. If you look at the sutural width and measure it, and we've actually done studies on this and published it, if you look at the actual sutural width, it's approximately 250 microns. It varies between 100 microns to about 400 microns. And 250 microns, as you know, is 0.25 millimeters. So now we know, historically, by trial and error, the orthodontist discovered that if you turn the screw of a palatal expander by 1/4 millimeter, it seems to have a beneficial effect over a period of time. So what's happening is that when you stretch the suture beyond 250 microns, you get these stretch-sensitive genes. And what happens is that you get signal transduction. And so the stem cells, which are found in the sutures, they undergo differentiation and they start producing, bone-forming osteoblasts, osteoclasts, and therefore you get sutural remodeling. So the recent research shows that the sutures provide a niche for the stem cell, for the mesenchymal stem cells. They're found in the sutures. And so if you split the suture, you've overridden the biological boundaries. I'm not saying you can't do that. I'm not saying you shouldn't do that. I'm just saying that this is kind of going beyond what the biology would represent. But if you harness the body's own mechanism, you can stretch the suture and without splitting it, and you will get those changes. The upside is that these sutures, craniofacial sutures, the circummaxillary sutures, they're in a state of balance. They're going to, it's checks and balances. They're going to balance each other out. And therefore, not only do you get changes inside the palate, but you actually get extra oral changes also in the face. For example, in the zygomas. And therefore, when you do this quote palatal expansion, if you look at the patient's face and measure, the volume of the midface increases to a small extent. And so inside the midface there, you've got the maxillary air sinuses, which also increase in volume if you measure them. And then behind that, you can measure the upper airway and see what effect quote palatal expansion has on that as well. So I think palatal expansion is not fully understood or appreciated. I'm not saying you shouldn't use MARPI or SARPI or any of those techniques, but there may be a non-invasive, non-surgical option, which is sometimes less expensive and more comfortable for the patient. So again, a lot of research
Can you
needs to be
describe what
done.
this looks like? For those watching, can you show us what such an appliance or such a treatment looks like? And those who are listening will describe it for you as well. Is that okay?
Say again, Jess?
Have you got any images of what a DNA appliance looks like that we can describe to our audio listeners and show to our visual watchers? And is this something that you think someone who has upper airway resistance syndrome may benefit from?
It's certainly possible. Again, I don't do a device-based diagnosis. My diagnosis is etiology-based. I want to understand where did this UARS come from. Let's say it came from nasal resistance. So now I have a choice.
Here's my question about making it tangible, Prof. Right? Here's help me out, because as the dentist, yes, we rely on the sleep study which is reported, and then yes, you're getting the official diagnosis from the sleep physician. But as a like, for example, our sleep physician that we use in the local hospital, they may not be familiar with this. They may not be able to recommend this or have the knowledge about this. So how can we as dentists arm ourselves with enough of like a screening system to figure out, okay, how can I best find out where is the obstruction, where is the problem, to help then filter out which is the best management technique for my patient?
Well, the first thing any dentist should do is to establish a strong collaborative working relationship with a sleep physician or an ENT or other doctor that has a similar interest and line of thinking. This is an integrative approach. And so we want to have the oral myofunctional therapist, the orthodontist, the dentist, the sleep physician, the ENT, working as an integrated group, and therefore you're going to get the best possible outcomes. Now, whether that model is generalizable and deliverable in the UK, I don't know, but certainly that's been my experience in the US, that you can work across these, disciplines and to get a really good outcome. So I would say do a lunch and learn. There's plenty of literature studies out there. The devices that we have been using, in the past and the future have gone through the FDA approval process. So we know that they are, reliable and they're safe. And number two is that they are covered in the US by medical insurance, for example. And again, I don't know how that would translate into Europe and into the UK, but the devices that we have been using have all been through the approval process to make sure they are both safe and effective. So get the conversation going with your medical colleagues, and that's the best way. And this is the reason that, going way back to the first question, why would I want to leave the UK, is because I had a chance to be a part of a craniofacial team in the US, and that is really where my understanding actually came from.
Okay, so to actually go further in the field, I understand that you get to cross the pond where it was you're in the action, then you're in the cage, you're in the arena to be able to develop and grow in that area. So again, I'm sorry to go back to my patient, but I genuinely want to help my patient here. So once we get the official diagnosis, do you think dentists should be using imaging, and what type of imaging, to actually measure the volume of the airway? And is that linked to upper airway resistance syndrome if the AHI is coming as low?
Again, wonderful question, Jazz. So it's not specifically about the size of the airway, it's the behavior we want to capture. But you're right, generally speaking, a larger airway diameter, less likely to collapse. So let's see now, in terms of what's my diagnostic protocol, what would I do classically in an ideal world? First thing I do is I take photographs of the patient, just like an orthodontic workup. You take the photos from the face, lateral profile, so on and so forth, intraoral photographs as well. And from those photographs, you can get some easy eyeball assessments, or actually do make measurements. And so we can kind of think about in terms of what kind of cranial-based phenotype this is, and get the information from the photographs. And this is the kind of thing that I do in my training sessions. I go through in a good amount of detail. This is not rocket science. Every general dentist that I have met can do this, and you can train the staff to do it as well. Not a big deal. So number one is we collect standardized photographs. Number two even before that, or in conjunction with, we need to have a sleep study. We need to know whether this patient has mild, moderate, severe apnea. Maybe they don't have apnea. Maybe it's suspected a differential diagnosis of UARS, for example. So now we have a sleep report saying we suspect this patient may have UARS because the sleep study is negative, and yet they've got daytime symptoms, excessive daytime sleepiness, feeling fatigued, feeling, chronic
Restless sleep,
pain.
would that be one whereby like I wear my watch and I get some very restful sleep according to my watch when I do sleep? And then would someone who has I don't know if you looked into sleep metrics and sleep measuring. Nowadays the Apple Watches and stuff, they're fascinating. I once gave my my prosthodontist colleague, I made him a what was it called, a prosomnus device, right? And then the next day his iPhone came up saying your blood oxygen was 4% higher than ever recorded before while you slept, and that was a fascinating piece of data, objective, collected. So how accurate and reliable are they? For example, the whole lack of restlessness for my patient, is that something that we need to take with a pinch of salt, or does it carry diagnostic value?
Well, if you look at this, the wearable technology has really moved really fast. And so the tracking devices that patients now have, like a smartwatch or a ring or so on and so forth, they are extremely useful. Some of those devices in the US have been FDA cleared for sleep tracking or even sleep diagnosis. So there's a blurry line between, do I need a full-blown home sleep test, or can I use my smartwatch and get the same amount of data kind of in a very easy kind of way? At the end of the day, that data has to be interpreted by a sleep physician. So you can use your sleep watch, you can use whatever you want, your Fitbit, whatever it is, to say, I can monitor my sleep. That's part of it. So now we have the facial photographs being taken. I have a sleep study saying, here's my metrics to show I have good, bad, or indifferent sleep. And then what I like to do classically is take a 3D CD scan, a 3D cone beam scan. And classically, the scan that I do goes from the cranial base down to the hyoid bone. And I want to capture all the information to say, okay, what kind of phenotype am I working with from a craniofacial perspective? And we do very specific measurements there to come back with, here's what we are finding. And the final bit is study models or intraoral scans. We take certain measurements. And the classic measurement that I took, this is going way back when I wrote my first book on this topic, is the minimum intermolar width. So we're at the cervical margin of the teeth. It's the mesiopalatal cusp of the first permanent molar, and you're measuring the minimum width at the gingival level there to find out how wide is this maxilla. If you go back to the studies, the first person to measure that width, well, not the first person, but the person who published it, was Jim McNamara. He's professor of orthodontics at University of Michigan. And he invited me to the US so many times. And in fact, he sponsored me to come to the US. And I wrote about at least 20 papers with Jim as my second author on those papers. So intermolar width, classically, if you said, give me a number, I'm going to take a message, I would say 38 millimeters for a typical Caucasian individual. If we look at someone from African or Asian origin, I would say maybe 42 millimeters. Now, again, these are just numbers I'm picking out to say, generally speaking, based on our experience. Of course, it's a individual based thing, but easy thing to do. Look at the study model, measure it and saying, is it wide? No. Is it narrow? And therefore, you have at least a starting point in terms of treatment planning. So we have a diagnosis, we have our treatment objectives, we make a treatment plan, and then we estimate how long it's going to take. And that's a classical kind of protocol that I follow to help people, help dentists to help their patients with these types of conditions.
So tell me about the platal expansion. How long does it take? What the device looks like?
Again, what it looks like is irrelevant because you never see the device. It's how it feels. Now, what we have inside the mouth and actually all of the body is proprioception. And so when the device goes into the patient's mouth, the patient should immediately feel improvement, immediately. So let's go to, the clothing store here, and I put on a jacket and it feels too tight. I'm not going to buy that jacket. It looks great, but it's too tight. It's not comfortable. When that device goes into the patient's mouth, there will be, wow, that feels nice. Or there will be a sense of, oh, this is okay. The body does not lie. So I'll give you a real life example. I'm doing a teaching seminar for pediatrics, actually. and we had 7 children who volunteered. Parents had the children volunteer to be, a part of the training part. And the first 6 children that we had, we put the device in the patient's mouth, and they all walked out of the office, and they were totally fine. Patient number 7, I put the device in his mouth, and within 30 seconds, he kind of spit it out. So that case, that device, that design did not meet that patient's requirements. The body doesn't lie. And so when it comes to placing a device into a patient's mouth, we're going to get biofeedback immediately. Of course, you'll have done your planning ahead of time to say, I'm going to get very close to where I want to be, possibly without any adjustments when I actually deliver the device. And so what is it that we're trying to capture here? Well, this is what you might call, quote, the bite. Okay, so we talk about the bite. And this is so important in terms of tying in the teeth with the rest of the body. So again, let's think about teeth and the bite, because this is going to determine where the device is going to go. So now we say, well, this patient had a malocclusion. And there are many different kind of definitions of malocclusions. Pick your favorite one, your favorite orthodontic textbook, and you've got a definition for malocclusion. Now let's turn the coin over and say, what is your definition of occlusion? And you can pick out any of your favorite kind of definitions saying, this is what I mean by occlusion. And then you can turn around to me and say, what is your definition of malocclusion and occlusion? Okay, so for me, malocclusion is a solution for a complex adaptive system to remain in homeostasis.
Mm-hmm.
That is what a malocclusion is. It's the best I can give you to give you at least reasonable function. It's a state of compensation. So a malocclusion is a solution for a complex adaptive system. Craniofacial oral tissues, you have 4 sets of tissues. You have hard tissues, bone, soft tissues, muscle. You've got the functional spaces, which includes the airway, and you have the dental tissues, which is teeth. That's a complex system. And the system itself is adaptive. You can move the jaw, you can move the teeth, you can move the tongue. It will adapt until it gets too close and it will regress down to homeostasis. This is the best I can give you, given the conditions I'm working in. That is a malocclusion in my understanding. Now we're going to turn the coin over again and say, okay, now what is your definition of occlusion? Occlusion is the end point of the body with respect to the plantar surfaces of the feet, and between those 2 boundaries, all functional spaces for physiological function have to be accommodated. So what we've done here is tied in the bite with the rest of the body. So what the device looks like is not important. What is important is what is the spatial signaling the body gets from this device. And the great thing is we can adapt and change and modify and adjust that device to get the best possible outcome. So that's a principle that I work from. This is not rocket science. You can call it a partial expander, you can call it a mandibular advancement device, so on and so forth. And there are other devices as well. And one of the things I want to do is show people to start with a very simple device that requires minimal or no adjustment. It doesn't involve partial expansion. It doesn't involve mandibular advancement, and yet has been shown and FDA cleared for the treatment of mild, moderate, and severe sleep apnea. So really the device is, an airway device. It's going to optimize the airway in these cases. And that could be UARS, or it could be something a bit more severe than that.
I mean, that sounds amazing. I think it's beyond the scope of this podcast, but I would definitely, very definitely pique my interest. I'm going to be researching more about the DNA device you said. But I know you're coming to the UK to do some teaching. I'm more than happy for you to share the details of that, so those who are interested in this space can learn more. Please tell us more about when you're visiting, because what I took away from today is think beyond the mandibular advancement device. Look at the etiological cause, which definitely has opened my eyes. But again, I need to probably bring you back for a part 2 or something. But in terms of those who wish to learn more, can you tell us more?
Sure. So I have written some books on this topic and several papers, and hopefully we'll be able to access those from the website. But next year in May, we're going to hold our first introduction to craniofacial sleep medicine for dentists, and that's going to be held in London May 1st and 2nd. And so there's some early bird discounts for people who want to register ahead of time. And so, yes, my idea is to be able to share this information literally worldwide. I've done, teaching in North America, Australia, Asia, Europe, and actually never done a event in the UK. So I'm looking forward to coming back to London, May 2026. And, general dentists, orthodontists, implant dentists who are interested in this aspect, we'll do a nice kind of 2-day introduction to craniofacial sleep medicine. And my idea is to give you at least one technique which you can then implement in your office as a starting point on this new journey.
Amazing. Well, I'll put the link to that in the show notes, and I want to thank you, Prof, for giving up time in your busy schedule to talk about such an important thing. You've definitely opened my eyes, and I'm going to hit the papers, hit the books again. You mentioned the main McNamara when I was doing my orthodontic diploma. His name was everywhere. He wrote so many books on it, and so amazing that you were headhunted by him, if you like, and invited. That's so cool, and I'm wishing you all the best with your sort of now new direction you're going in. Obviously, so you are no longer at Stanford?
Correct. I finished there in September. I have a new startup company called Rima, and we're looking at devices which are extraoral, could be used by a dentist, could be used by a physician. Again, I want to make a very flat field in that what is the best option for your patient. It might not be surgery, it might not be CPAP, it might not be an oral device. Are there any other options? And there may be other options, including pharmaceuticals. And so the idea is to have a broad range of information to make the best decision in terms of patient management.
Thanks so much. I'm going to put all the links to reach out to you in the show notes, and of course the link to the event in early May 2026. Thanks so much for your time.
Thanks, Charles. Thanks for having me. It's been a pleasure.
Well, there we have it, guys. Thank you so much for listening all the way to the end, as always. And of course, there's a quiz attached to this. Recently we ran a poll. We asked you, where do you consume these episodes? And 41% of you said you listen or watch on the app. That is amazing. So if you're not already on the app, get on there. It's Protrusive Guidance. It's on Android. It's on iOS. And what we've got planned for 2026 in terms of really making a difference in your career is amazing. And of course, by the time this episode launches, Protrusive AI, aka Ask Jazz, has already been launched, and I'm hoping you guys are loving it and blown away. So we have so many great things on the app. Interestingly, just 17% of you watch on YouTube, and everyone else listens on Apple and Spotify. But remember that you can listen on Spotify and Apple, but then you can answer the quiz on Protrusive Guidance so you can get your CPD or CE credits. This episode, like many of our episodes, are eligible for CE credits, and we are a PACE approved education provider. I want to thank our guest, Dr. Dave Singh. Now, he is coming to London. I think the date is May 1st and 2nd, 2026. He's teaching a 2-day course with Dr. Kalina Borska, and it's the Introduction to Craniofacial Sleep Medicine. There is an early bird rate, and the early bird code is earlybird20, and so I'll put all the links and everything in the show notes. If you like what Dr. Dave Singh had to discuss today and are interested in learning more about an etiology-based approach, then I think this will be a very interesting course. All the links and everything will be in the show notes, so please do check it out. And thanks again for listening all the way to the end. I'll catch you same time, same place next week. Bye for now.